One additional presentation that fits our program from Professor Youbin Wang, my very good friend for past 10 years, talking to us about tension reduction surgery for large chest keloids. Professor Wang.
Okay, thank you very much. Good morning. In this presentation, I'll talk about my appearance in chest keloid treatment, especially with very large keloid. In my clinical practice, I met many patients with very large keloid. And how to treat this patient, I think, is a very important topic. So in this presentation, I'll give you some cases of the patient I treat these years. The content of the presentation include the 4 parts. The first is the difficulties in keloid treatment of the chest with very large keloid. I think there are 3 major difficulties in such keloid treatment. One is anatomy and patient circumstances. And as we know, the chest is a very high tension area of the body. And how to reduce the tension is very important for us to treat the keloid. The second is complicated pathological, physiological circumstances. In a paper studied by my students, we found the keloid infection is very popular in chest keloid. We found almost 50% of the patient will be developed infection. So it's not important for us to treat the keloid and infection for the same time. And the third is limited treatment method. These days, we discussed many treatment methods, but for very large keloid in the chest, we often find that not so much ways, not so much method can be applied for this patient. So how to treat the keloid in the chest is a great challenge. The following is a list of customer keloid treatment methods in our country. The first is surgical removing with direct root closing. This is perfect suitable for very small keloid, but with very large keloid. If we direct close the wound, the skin tension will increase in the operation site. So this method is suitable for small keloid with not much tension, but no indicate for keloid, for very large keloid. The second is keloid drug injection. Yesterday, many professors talked about such topic. I will not discuss more about the detail of this method. But for this method, it have a little effects, I think, in reduce local skin tension. The third is radiotherapy. I think radiotherapy is a very important help for keloid treatment, but it also have little effect on reduce local skin tension, I think. It can prevent inflammation, and in some times it can influence immunity of the local skin, but I do not think it can reduce the tension of the local skin. And the fourth is laser treatment. Yesterday, many professors also talked about laser treatment in keloid treatment. I also think it have a little effects in reduce local skin tension. So for the patient with very large keloid in the chest, which with very great tension in the area, how to treat this patient, such patient, is a challenge. The following, I will describe a patient which with unfortunate treatment history of a large chest keloid. This patient is a 45-year-old female, and her major complaint is large chest keloid, which itch and pain for 20 years. And the illness began with some folliculitis 20 years before, and some keloid formed and converged and enlarged. And many treatment methods were used without effects. And the body check finding include many keloid in her chest and distribute along the middle line of the chest. The longest one was about 15 centimeters, and the color of the keloid was red in keloid green area, and some area was white because of the treatment before. And the keloid was hard and above normal skin with pain when touching. And this is her treatment history. The first treatment happened in 2020, and from January 2020 to August 2020, he received laser treatment with toxin injection with no obvious effect. And the short-term 19 was given also without obvious effects. And in August 2020, he received punch treatment and plus TA and 5-FU injection plus botulinum toxin injection and plus SRT-100 radiotherapy for 4 times, and also laser treatment for 5 times. And is in fact, some of the keloid, some area of the keloid became soft and the volume was reduced at first. But local recurrence occurred afterwards. From 2021 to 2025, he also received some treatment. One is one-time laser treatment with TA injection, and 10 times strontium-90 treatment, 10 times, and with little effort, and always radiodermatitis. Follow on, she was treated with laser treatment and betamethasone injection, also without effects. This is the picture before and after all this treatment. The 3 picture is the keloid before all this treatment. And the final picture is the picture when she visited my office. We take the photo. From the fourth picture, we can see some of the keloid continue growing, and some area was white because of strontium-90 irradiation treatment. So he came to my office, to our hospital, for help. How to treat this patient? My treatment techniques is prefabricate skin flap in low tension skin area, and then transplant it to the skin area with high tension to reduce the tension of such area. And this is my method. The expanded parasternal intercostal perforator flap. And this is a picture of the parasternal intercostal perforator flap designed. And the first picture indicates the internal mammary artery perforator. And what? Which one point? Oh, no. No. Yeah. Yes, thank you very much. Yeah. I think this is the vessel. This is the vessel of internal mammary artery perforator. It from the midline area and distribute to the side of the local chest, of the wide side of the chest. And this is the picture of the skin flap. This is the flap of parasternal intercostal perforator flap. We can use this flap to reconstruct the wound of the chest. But if we direct use this flap, the tension in the area, in such an area, will be very high. So how to reduce the tension of the area which we use as a flap? It is a subject of our study. This is a procedure. We create expanded parasternal intercostal perforator flap. The first picture is when we insert a tissue expander under the flap area. This is the design of the flap and the wound after keloid resection. And this map indicates the vessel of the flap, and this intraoperative procedure photo of the flap raised. And the final photograph is we transplant the flap to the wound and close the flap, close the wound. And for the woman, we also use this method, and the 2 tissue expander were used. And this is after the operation, about 7 days, about 7 days after operation. And we can see skin flap was transplanted to the area with the highest tension, skin tension area. So I'll give some of the cases I did before. This patient, I gave the patient operation in 2018. This is the picture before the second term of operation. And the middle picture is the surgery design. And the third picture is skin flap transplanted. And this is the photo recorded in 2025, about 7 years after operation. No, 7. Huh? Yes. No recurrence. Beside chest keloid, he also have keloid in the shoulder, in the back. In 2025, he came to our hospital for more help, for more treatment. So I have such a record. This is another person with very large keloid in the chest, and some keloid infection occurred. This is my design. 4 tissue expander were used, and the middle is a picture of the skin flap dissection. And the third is skin flap transplanted. And this is photograph this year. I asked for him to photograph for me. He gave the picture. This is also 7 years after operation. So this is the third woman who also with a large chest keloid and also with keloid infection. We can see the infection area of the keloid. We also use such procedure to remove the keloid and reconstruct the wound. This picture is 1 year after operation when she visited my office. Also, maybe I will give some discussion and conclusion. First, skin tension is a key point in large chest keloid treatment, I think. So I think skin flap transplantation is an effective method in reducing skin tension. And if we use this method, we should consider the donor site area, the donor site skin tension. So when we use this method, the donor site tension should also be considered. So we need tissue expansion to create more skin to transplant to the area which need and keep the donor site with normal skin tension. So my conclusion is skin tension balance with tissue expansion may be a good choice for large keloid in the chest. I think this method may be a help for such patient treatment. Thank you very much.
So, questions? Can we throw it? It looks like it's safe to throw.
I do.
Thank you very much for showing your results. Do you use any special sutures or suturing techniques?
What?
Suturing.
Suturing?
Stitches.
Oh, yes. I think in such a patient with a very long incision, we often use buried stitches, and in some area which the incision is not regular, we often use interrupt suture with a very thin thread. I think it's very important for us to cause no trauma for the incision. I think it's very important. Little trauma for the skin.
So I'm going to pose a few questions from the chat group from the remote audiences. This patient of yours, did any of patients receive radiation after surgery or not?
Yeah. Yes.
They all received radiation
Yes.
after surgery.
Yes.
1 second, please. Let me just read some of the questions from the audience who have had. So it looks like a lower version of a delta pectoral flap based on anterior chest intercostal vessel Did he take fascia with it, given the arc of rotation and concern about vascular integrity? Did you also take fascia with your flap or not?
What?
Fascia. Did you remove the fascia as part of the flap or not?
Yes.
Yes, the fascia was removed. Yeah,
Yes. The vessel is under the fascia.
correct.
Yes.
Correct. Correct. All right. Please go ahead. Questions for Dr. Professor Wang?
Yeah, or we can, because we're actually on time. So, and then we can ask if anybody has any questions.
Yeah, I've got a question. Firstly, Professor, well done. Lovely result. In one of your slides, you say what excellent results radiotherapy have.
Yeah.
But in the first case you showed, you injected chemo and he had recurrence. Why did you not give radiotherapy? In the first case you showed.
First case.
Was this patient treated by you 5 years earlier when the patient received chemotherapy or by somebody else?
Yeah.
Did
Yes.
you use the chemo?
Just had
yourself?
chemo.
Some chemo.
Laser and chemo. You
Okay.
didn't show any with radiotherapy. The first case was just laser and chemo.
May I, when you showed that the patient had chemotherapy injections and laser, was that you who did that treatment or somebody else?
Somebody else. I did not treat.
That was done by somebody else, not Professor Yang.
Thank you, Professor.
Yes.
Other questions? There's
Yeah.
Have you tried or did you consider when you move all the way you move tissue, sometimes you can expand it and it's easier and sometimes works better.
Oh, I do not understand. You see, when I remove the expander, yeah, thank you. Yes, what is your question?
If the question is, have you tried that we put sometimes tissue expander
Yes,
and then it's easier to move?
yeah,
It seems to be very kind of tight to me. So have you done that any cases with tissue expansion?
yes.
Or you-
With tissue expander, the skin flap will be easily removed from one place to another.
Right, because
Yes.
You have a larger piece to
Yes,
move, right?
yes,
Rather than make it look like.
yes.
Good,
It's
thank-
very,
that's all
yes,
I have.
thank you very much.
Thank you.
any other questions?
Personally, I think this would be the patients where we should discuss systemic treatments. And I really don't understand why we don't have systemic treatments. And I'm not talking about vitamin D or anything like that, but something that is anti-inflammatory and anti-proliferative. For example, like methotrexate. We already heard from Michael that dupilumab wasn't really effective in the small series of patients. Maybe there's still a session to discuss systemic treatments.
We could have another 5-10 minutes of conversation if you wish. Then we go for a break and start 15 minutes later the next session. Is that what you wish to do?
I mean, well, I guess what I would say is, I mean, I don't think we know what systemic treatments. I mean, that's part of, some of the research interest is to try to figure out what would work systemically. I don't know if anybody is using.
Yeah, this is what these patients need. These patients need systemic treatment. Right now, we don't have any systemic treatment. Therefore, they receive all kinds of treatment. Dupilumab that you mentioned does not work, did not work, will not work.
Anybody who tried methotrexate
Systemically?
systemically?
Well, there are case reports anecdotal for patients who have had cancer chemotherapy, high-dose treatments, and have had keloids. There is some response in the keloids, but the toxicity of methotrexate, systemic chemotherapy drug that we can use, perhaps outweigh a lot of benefits that we can draw with minimal efficacy.
Depends also on the dose, of course, again.
Of course.
As dermatologists, we prescribe methotrexate for 10 years continuously for
Correct.
psoriasis. So why shouldn't we use it here?
That would
Yeah.
be a wonderful idea to implement in Amsterdam and do
Well,
a
I
clinical
started-
trial.
doing
How many
that.
patients have you treated?
No, one, but he had like 20 to 25% of his body surface involved with keloids, so which is incredible. So
And
I
you
thought that
see-
would be a patient.
What dose of methotrexate do you use?
We started low with 10, then 15, and then we
Weekly
look
or
at the
daily?
dose, milligram per day. That's
day,
what
10
we
milligram
use in
per day.
psoriasis, and we go up to 20 maybe.
And what kind of responses have you seen?
Not yet. I don't know
Not
yet.
yet.
It will take like
It takes
3
a long
months
time.
or
Yeah.
longer.
Hi, may
Oh, that's all right. You can go first.
can I share an experience? I also have one patient that I had to use methotrexate on. She had psoriasis and also she was developing quite a few very bad, difficult cases of keloids, and I think she improved a little bit, systemic, and we've used 15 milligrams per week. But it was just anecdotal because, of course, it's just one case. But I have a trial going on of a new master's student at the university that we are doing injectable methotrexate and in earlobe keloids. So maybe next keloid symposium we will have an answer for that.
Yeah, it would be wonderful to see these data, to see whether or not the treatments work or not.
Thank you. Had to fight for it. I got two questions, one for Professor Wang and one for Lamont, if that's okay. The first question, Professor Wang, is when you use the tissue expanders, how do you help the patients to cope with the body dysmorphia? So the fact that they've got these large lumps in their chest, do you say anything to them? For example, when they have to meet their friends and outside, how do you, because what I'm thinking about is if I have patients that we struggle to treat and we refer to plastics team, and I'm going to be showing them some of the pictures that, the tissue expanders, to set expectations. What can I say to them to relieve their concern?
Yes, tissue expansion is a very long time procedure. So the cooperation of the patient is very important for we successfully finally give the treatment. So when the patient visits my office, we'll discuss the operation, the method with him or her deeply. And some of them refuse to use this method because it's very long time and time cost and money cost. So I think the patient who choose this procedure, I think is they find no way can cure the disease, and then please hope for the method. So this is also a very great burden for a surgeon to give such procedure. So we will arrange the treatment procedure very carefully. Very carefully.
And roughly how long do you keep the expanders in for these patients with these very large flaps?
About 6 or 5 months. Yes.
Thank you.
Long period.
Thank you. And just quick comment for Lamont and perhaps some thoughts. So I'm a primary care physician by background based in the UK. And I just want to comment on the app idea. I think it's a great idea. I think it captures a lot of missing data points, particularly regarding symptom changes. I think we talked a lot about cosmetic appearances, but equally a lot of our patients seeking our help is just seeking symptomatic relief. And I think that's not really captured by how we normally measure outcomes. I think it's great for researchers. It provides more data points to further research. I do have a background of doing some AI research, so I do want to make a few comments. I think the challenges that you may have in developing the app is that AI normally requires standardized images. So that's why radiology is the forefront of AI processed imaging. The images get feeds into the AI algorithm. But I think if you have patient taken pictures, you might find some challenges in getting the AI algorithm to pattern recognize. Second is costs. Again, I'm not really sure. I mean, I would love to use that app if it's free to use. And I'm sure a lot of patients would love to use that. But again, I can see you're an MBA as well, so I'm not really sure what the business case in terms of where the funding will be.
Yeah.
I think it would be a great tool because when it comes, at the start of the conference, we talked about funding as a big issue with keloids. And I think that app is a great tool to show that keloid is not just a cosmetic disorder as classified by the NHS, that there are actual symptomatic needs from patients and it really impacts the quality of life. And if we have the data from your application, I think it could really open up funding pathways and therefore more research opportunities. Finally, 2 more points. I think as a primary care physician, if the patient takes a picture every day and have 28 images to look at every time they come and see me, I think that would be a bit overwhelming. But I think the patients might like that idea. So yeah, just a few thoughts and points, if that's okay. Thank you. But thank you very much for looking into this. I think it's a really helpful piece of work.
Yeah, thank you for the comment. So the symptoms is a big component of it. And what I would say for the pictures is that if the goal would be the algorithm would not make it overwhelming for a provider. So it basically would be set up to give longitudinal changes. So they wouldn't necessarily send you 20. If it was 30 days since they saw you, they're going to send you 30 pictures. It'll be a report about the progression. As far as the technology, there are already dermatology apps already that can scan lesions and look for pre-cancerous changes. So I think there are models of how this could work, but it's going to take people like you to have knowledge and in order to help craft it and make it as user-friendly as possible. So
this is being forward-thinking and thinking in the future, because this is the beginning of, as I said, this is a keloid registry formation. This is at its infancy. It's going to take a lot of time, a lot of effort. A lot of things have to be ironed out. This is just right at the beginning of it with a ton of challenges ahead. So I think everyone should help with that.
I think the specific challenge you may have is the existing dermatology apps are normally for mole screening and lesion screening. So I'm happy to be corrected, but I don't think there's a longitudinal model where an AI algorithm is trained to observe changes of a lesion that may be taken or pictures taken at a different angle or manner by the patient. So I think that would be the challenge that you have to face, and that's something I'm happy to look into.
Yeah, correct. And then as far as the funding is concerned, I think it's one of the reasons why I want to get feedback. First, you got to gauge what the demand is, and I think there's ways of getting something like this supported. I'm sure a lot of us have been contacted by biopharma to be advisors for keloid drugs, and one of the biggest challenges is having something that's quantitative that you can track changes over time. So if something like this is adapted for patients, because all patient driven. So if it's user friendly for patients, you can make it more complicated on the back end for a physician facing or biopharma facing. And ultimately, the way I look at this is that that's where the funding could come from. I mean, obviously, my goal would be to make it free for patients. And the way to then use that is no different than what Google does for all the search information, right? It's free for people to use, but on the back end, they use it to support other ways to support the platform. So that's the goal. The first thing though is to make it clinically and useful and patient friendly. So that's my initial goal.
Again, we could have a whole day of conversation about this. These topics are so delicate that there's so much involved. So we can have a whole day discussion about this. Can we change the topic to other questions from AI? Any other questions?
There's a publication by the group from John McGrath on the use of imatinib for keloids, and that's something I wanted to put out for discussion. This was a patient who was treated for a cancer with it and also had extensive keloids, and the results from this single case were quite impressive. So does anybody else have experience with imatinib? Have you used it? And from your oncology background, how would you judge this as a single treatment for the keloids?
Yeah, I'm quite familiar with these drugs. I have tried a lot of these drugs that are single case reports out there. I've tried interferon, I've tried tamoxifen, I have tried a bunch of other drugs, but unfortunately, these need to be properly assessed. One patient doesn't make it. The second thing is, cost of imatinib comes approximately $10,000 to $15,000 a month. You need to think about the treatments that patients can afford, especially in a situation that the drugs are not indicated for particular disease and patients have to pay out of pocket in United States to get imatinib. I've had hard time reaching to the pharmaceutical companies to get approval to use their drugs as an investigational study for keloids, drugs that do make sense. They're quite hesitant to actually even sponsor a small study and provide free drug to the patient. So it's a good, these are great places to start, but again, need to be properly studied.
In Germany, we have a generic for it, and it's rather...
Imatinib is generic name.
Yeah.
It used to be Glivec.
Yeah, so
That's already the generic version of it.
we have a reasonable price for it, but have you ever tried it on a patient or anybody else?
I haven't. No, these are cost prohibitive. They're cost prohibitive. We have tried to use several of these TKIs for treatment of the keloid patients. A few years ago, I tried one of these drugs. It's just, these are cost prohibitive. It's not doable. Couldn't even get the FDA to approve it. Tried to put an investigational study for Glivec to the dermatology division of FDA and see what kind of answer you get.
So I mean, we're talking about biomarkers. I think that the problem with some of these, single cases is that, if you don't have any data to support why you want to use it and it fails, then you think it failed, but it may not. It could be that the patient selection may not be correct, and so I think that's the importance of collaborating with our translational researchers so that we can identify which patients may benefit for some of these drugs and do it in a more evidence-based way.
The one drug that several years ago I thought would work well was sorafenib. Sorafenib is used for treatment of hepatocellular carcinoma, renal cell carcinoma, et cetera. And it's fairly generic. And it's basically, it's called a dirty TKI, tyrosine kinase inhibitor, that inhibits different pathways. It's not very unique. And I put an indication, I put a protocol and an IND application to the FDA dermatology department. They rejected it. I was going to treat patients with very advanced keloids with that. I ended up treating one patient who visited me from Africa with huge keloids. I sent him back, told him, try this in Africa according to protocol, and he did, and it didn't work. One patient. So these things need to be really hashed out.
Well, that's why I'm asking the group if anybody else has had single case experiences. Okay, thank you.
So I can provide my in vitro approach to it. I think we've tested maybe about half a dozen of these tyrosine kinase inhibitors. Nearly all of them are fairly toxic at low doses. And but you can pick a low enough dose where they are effective, and they are kind of effective. I think in Shanghai, I showed you our data with nintedanib, and I can probably show you data for a couple of other tyrosine kinase inhibitors and what they do in vitro tomorrow. So there's room for them, and we can generate at least data in vitro with the 2D cultures. You can probably try them out in 3D cultures, but eventually you will have to try them on actual patients. Using some in vitro based data and some computational modeling, you can predict some potential dosage that you can try in the clinic, but that's about all that we can do.
Yeah, imatinib is fairly well tolerated. It's not a toxic drug. So is sorafenib.
I'll ask some question about the Keloid treatment by Professor Nielsen. In the presentation, I find you first use creep therapy to reduce the volume of the keloid, and then do some dissection Is that right? Yeah. And then after
I undermine.
also use peripheral therapy.
Yeah.
Is that right?
Yeah.
And my question is, if the peripheral therapy can cause skin necrosis and cause wound after the treatment.
The question is if the skin necrosis, if you apply the cryotherapy long, then I think so. That's why I apply it 20 seconds, 30 seconds, and not longer.
Oh.
And there's no skin necrosis.
Okay, okay, I understand.
But when you do it 2 or 3 minutes, I think yes.
Okay, you just use cryotherapy to prevent recurrence.
Yes.
Not use radiotherapy. Is that right?
No radiotherapy.
Okay.
I do in other cases. This was to try if cryotherapy works as good as radiotherapy.
Okay.
In small cases.
Okay, thank you.
If I could briefly comment on the study that you did, I thank you for using the record response criteria. A comment came as to why do we call this stable disease when you do surgery and this is gone. The record response criteria is, again, forward thinking. This comes from RECIST response criteria in oncology. When we treat cancers, what matters to the patients and what matters to researchers is, one, if you treat a disease, whatever disease it is, it's a cancer, lung cancer, or a keloid, can you induce complete remission? Can you make this thing to go completely away? That's important. Measuring that is important. Measuring the time to achieve complete remission is important. Duration of complete remission is important. Time of progression is important. And what the progression would look like. Say, if you treat a patient and 2 years later, the keloid has grown back to where it was day 1 after surgery, you basically induced complete remission for a period of time, then you had disease progression, and then you achieved for 2 years stable disease. That means that the intervention, the best it did for 2 years, kept the disease under some level of control. It didn't make it worse, it didn't make it better. These are the basic elements of statistical analysis later on. And statistical analysis is extremely important because we are forward thinking. 10 years from now, hopefully there will be 10 different clinical trials. Then you can compare these clinical trials. This treatment induced 25% complete remission that lasted 5 years with 10% stable disease, 10% progressive disease. The other treatment induced 55% complete remission that lasted 15 years. These are the RECIST criteria for oncology was created exactly for that purpose, to be able to do comparison across clinical studies. That today we cannot do with any clinical study that is done. Somebody uses Vancouver scar scale, somebody uses this scale, somebody uses success rate, somebody uses no recurrence rate. We need to have harmony in how we measure response, and we call that response criteria. I introduced it last year in Shanghai. I appreciate you using it. This basically is replication of RECIST criteria in oncology.
Dr. Birkenstoffer, is that you, Albert? Albert, you made an interesting comment that you used low-dose methotrexate, oral methotrexate, up to 10 years. Of course, you have to remind the people here that that is a carcinogenic drug, and you're giving it for benign disease. What's your comment? Well, you can have my microphone if you want.
Well, I think we have a huge experience with it.
Okay. Yeah.
And in dermatology, using it in a low dose, and we see really very little side effects. Of course, you need to keep on the screening to look for side effects. But
long term.
Yes, but we do it for psoriasis and for patients that have often less burden than those patients that we are talking now about. So I think it is fully justified in terms of burden of disease, but it needs to be effective. And this is what we really don't know. I knew that there were some case reports, otherwise I wouldn't have tried it. But it's anti-proliferative and it's
It's not particularly effective, Dr. Albert. I've been to many of Dr. Turgan's talks through the years, and he's injected methotrexate into the keloids. Not much is seen. He's got a lot of experience there, of which I'm well aware.
All right.
I think systemically.
The session, yeah, this is different.
I want to make one more comment, if I may, brief.
Because we need to take a break and then we
wait,
the next
but
session. Please go
one
ahead.
shouldn't always defer the discussions after a break. It's never the same. The discussion should take place after the meeting. And Dr. Wang, Professor Wang is here, and anyone that deals with keloid will know what wonderful work he's done. You can't find surgeons who will do what he does for these poor patients. You know, with this tissue expansion, you have to be aware it's a very tight feeling, and he presented wonderful cases. You're very correct that you asked him to talk.
Proud of Professor Wang. That's why he's here.
Well, I'm just congratulating you. I'm allowed to do that.
Absolutely. We congratulate Professor Wang as well. One quick comment before we break. Saj, where are you?
Just a quick announcement to let everybody know that the Keloid Symposium is on Instagram. And we'd be really grateful so that we can spread the word and invite more colleagues to future meetings. If you could follow the page, if you're on Instagram, and the handle is @keloid.symposium. If you can like the stories and posts on the page, and if you can tag @keloid.symposium into any stories and posts that you do. And please keep an eye out throughout the year for announcements for the next meeting in Paris. And please share and like those. And finally, if you're a speaker and you'd like to be tagged in the photos that we're taking, please can you give me your Instagram handle and we'll make sure that you're tagged as well. Thank you very much.
I'm proud of Saj for all the effort he has, but this is all his effort. Thank you very much. Let's take a break for 15 minutes. We come back.
Ga jij nu maar eens naar beneden.
Nice.
It is not carcinogen. I mean, it's
Can I give this
inhibitor.
Yeah.
It doesn't use so frequently.
Yeah.
We're not using it carcinogen.
Yeah.
Hi, how are you, Sal?
Hello.
With systemic treatment.
Oh, yes, please. I'm really I have some patients.
Today I checked.
Oh, yeah.
And
Which is the normal dose.
Yes.
Methotrexate you're using?
Yes. And I work with Professor. He is
En zo uiteindelijk goed voor je te doen.
So we work together and I try fascinating with patient who
Met ook gewoon een beetje
op. But we try with it's an analysis of picture. Is keloid of
Ja, en gewoon verantwoordelijkheid dat alles
in 6 months treatment, and it's in French, but the is lower, decrease of 50%. So this keloid in 50%.
But the treatment was only tofacitinib, no other treatment. She had also other. Okay. Oh, yeah.
But we decrease treatment because I treat with 4 patients tofacitinib.
The itching, that often responds very well on the JAK inhibitors.
Yes, but I think this patient
En ik vind het wel van, ik zeg over psychosociale dingen. Dus ik heb echt
And I
wat je levert naar dit vragenlijst voor littekens, veel meer kwaliteit van deze patiënten. En dan litteken specifiek. Litteken volgens mensen, maar dan heb ik dacht ik, nou, we ging even over het litteken. Al mensen van de sociaal tegen of dat soort dingen. En daar waren eigenlijk nog niet echt. Ja, de smart heb je dan natuurlijk wel, maar daar is eigenlijk heel weinig ervaring over. Toen dacht ik dan voor keloïden. En daar kom ik echt niks. Nou ja, hij noemde het dan Keloid. Ja, maar ik was er weer op. Dat is echt vragen. Dus ik denk echt.
Ja, uiteindelijk zou ik dat ook willen ontwikkelen. Kijk, ik heb
kijk op gevalideerde
ja, of daar vraag aan toe, want dan moet je kijken. Ik weet nog dat ik binnenkomst bij het
I think
was de scarpje net een beetje, ik weet niet,
in terms of pathways, the check inhibitors would fit quite well. One of my
je ziet dan niet waarin je zag heen, bijvoorbeeld, ja, het zal er niet overal zijn. Dus dat wordt eindelijk, dus het is goed geweest wel je zou kunnen kijken, kan je
theoretically it would be good for theoretically.
een stuk
But not all, rather small. No.
Klein beetje kleiner. Klein beetje over eten. Dat vind ik spelen. Ik vind wat, ik vind de man het andere vrouwen. Dus jou opgeleid bent.
Ja, dus ik leid het. Over COVID en de culturen. Dat hebben ze ook allemaal. I
also it's different different pathogenesis. Here for mandibular chest, the back again is different. So
That's good. Safer.
Ja, microvascular.
Nee, dat niet, maar...
I didn't know what if it doesn't work.
Het stil maar weer. Dit was voor
You don't pay. But still, if it's off-label,
heel leuk, maar ja, gaat dus.
Then it goes on the budget
van mijn eigen
partner. That's
Because we have also
yeah, but also in the Netherlands. So the
maar ja, als je allemaal precies weet, dan denk je wat is dan blijft voor de hij zegt
and then
maar hij net
find your way.
Ja, en die had gewoon een plaatje
so maybe it would be a good treatment, but
not for those. That's true.
It's
not enough for
zelf.
No,
Dus dat is een beetje prima.
It's vanished even in 6 to 8 weeks, but not.
Dat zijn natuurlijk best wel.
Probably you need to.
I think because for my patient at 3 months, yes, no effect, maybe little.
Yeah.
But after 6 months, she decreased with all, and now
donker daar en hij zijn
very
Well, good to know. Thank you.
Als je er nou helemaal af bent, maar je hebt
Yes.
Ja, precies. Inderdaad. Beetje uitziet en bulky en je kleren niet aan kan, lastig.
Think about that one, but that will be difficult unless Galderma really wants themselves to put some effort and money in it. Yeah, Galderma is very close to dermatology already. Yeah. No, we don't have it. Not yet, at least.
2 dagen in de week.
So that's more difficult then. Yeah. Not yet. Okay, thank you.
Oh ja, ja.
Dus aan wie weet of ik een shared decision is. Ik keek mensen aan en ik dacht dat ik van mij dat ik zelf ook niet zo gestudeerd werd.
En welke keuze
Maar
belangrijk?
dat ik denk dat de patiënt heel erg kan adviseren om niet te opereren of te zeggen ik doe dat niet, want het komt sowieso terug. Ik bedoel meer, je kan mensen wel zeggen van
Deze keuzes
dit-
heb je, hè?
precies, en hier moet je misschien
Maar-
wat vaker naar
Ja.
terugkomen en hier misschien niet, maar we weten het ook niet. Dus wat is je voorkeur zelf, zeg maar, toch? Hij snapt dat echt. Oh, alsof je het veel kunt kiezen. Oké, laat maar.
Ja, maar Frank, je moet ze officieel ons vertellen. En ik leid hem ook in als ik zo'n ding
Ik
zie.
weet het zelf ook niet. Het is allemaal natuurlijk expert opinie. Ja, het is ook best lekker om te zeggen. Patiënten zijn soms ook tevreden naar als ze zelf het idee hebben van ik heb er zelf over gevraagd. Maar ook zeggen, ja precies, dit was mijn eigen keuze in plaats van dat het zo opgedrongen is.
Kijk, ik zeg ook altijd tegen mensen van officieel, hè, als ik met zo'n crème kom, dan zeg ik ook, ja, je hebt ook, kijk, we zouden kunnen injecteren, maar ik vind hem daar te groot voor om heel eerlijk te zijn.
Ja.
Dus om dat als eerste stap te doen, nee.
Ja, precies. Of wel, als je dat heel graag wil proberen.
Ja, dan kunnen we, maar dan natuurlijk qua verwachtingen niet hebben dat het heel snel wordt. We kunnen hem heel snel doen laten afvallen met cryo. Wat ik heel graag wil, dat vind ik ook beter.
I don't want to sound, but I want the video.
Plan is. En dat we uiteindelijk wil ik dat echt niet. Hè? Ik wil eerst een stukje vlak. Kijk, hoe vlak we krijgen. En dan zeg ik, als er dan in de huid nog wat plekken zitten, wil ik niet aan blijven prikken. Dan daarmee verklein ik de kans. Graag heel veel. Maar daarmee vraag ik van nu een bepaalde tijd nu leven op het moment om wel samen dit traject aan te gaan. En ik weet niet wanneer dat traject stopt. Of dat nu een maand is, een half jaar duurt of een jaar of langer. Dat durf ik niet te vertellen. Maar ze zeggen, ja, maar dat de eerste die mij eindelijk durft te vertellen, zit.
Ja, precies. Ja, dat denk ik ook.
Dat vind ik.
Ja, maar en ik eerst het ook niet kijken. Maar ik had eerst kan het nou daar zo weinig. Nu zie ik deze mensen en dan denk ik, oh ja, er is gewoon, naast het geen geld is, en weinig geld denk ik, zijn het ook wel mensen die wel veel doen, die ook gewoon een beetje ouder uitkomsten doen. Echt van,
Weet je wat een kind zei? We moeten daar kijken. Hoe zit niet in dit stuk.
Sorry.
Dat is wel een zorgstelling, maar meer op een tentoonstelling voor cliënten. Maar hij is echt een oude man. Hij moest die tussen staan. Hij zegt, jij hebt eigenlijk een probleem. Het is heel vaak kijken naar mijn show.
Ja,
dat
hij
vindt
is gewoon heel gemeen te doen eigenlijk. Ik vind dit helemaal geen goed resultaat. Sorry.
Heel grappig, hij is ergens vorig jaar toen ik zat gesproken dat ik aan zijn zo. En toen zei hij, wat jij vertelt, het anders.
Ja.
En ik kwam ook aan het eind en wil ik weer niet
Ja.
En misschien is het maar beter dat iedereen het zo goed heeft voor de eerste.
Ja, precies. Dat is allemaal even. Ja, maar dat is wel. Ja, dat ik het buitenlijk heb op uitgestudeerd. Ik jaar geleden ongeveer van ongeveer. Ik denk dat in de tussentijd toch wel iets, ja, bij meer ontwikkeling op het gebied van. Er zijn wel andere vragenlijsten, er is veel meer bekend over.
Maar veel op zich wel. Stuk, weet je wat het is? Ik wil daar geld voor.
Ja.
En het klinkt een
tijd.
Ja. En dat ik ervoor betaald heb.
Ja.
En dat weet ik, en gaat niet in die want dan gaat het dus nog niet.
Ja,
je zal er zo een beeld zelf stellen.
Ja. Nee, maar we moeten er helemaal naast het nieuws gewoon moeten doen. Maar goed, ja, of je zou gewoon kunnen beginnen met een soort plannetje maken. Dus bijvoorbeeld de dataverzameling van een groep. Dat systeem.
Waar ik nog over ga praten, het gaat hier nog. Ik stop morgen. Kijk, ik ben hij gaat moeite met hem hebben, is dat hij vaak staat stopperaan terwijl de input moeten mensen eens weten waar het vandaan komt. Ik heb wel eens gezegd van als je mij vandaag dus niet in dat is samen met mij is, want je had van hij is de moeite die dat kan niet. Dus ik zeg zo morgen heel fijn als je het bruggetje naar mijn gaatje maakt.
You know, diabetes is apps. People could care less about, right? And so the question is, what is the in-use, you know,
geen cijfer en zo.
Ja,
En
dat
meer
mij ook
knuffelen.
terugkomt. Ja.
En dan de mensen ook, ja, wat deed ik daar? En dan denken mensen ook, ja, laat maar zitten dan ga ik het zelf wel weer doen.
Ja.
Daarheen om zijn verhalen te horen.
Ja, de collega was in het poli. Daar heb ik ook dingen terug. Hè? Snel. En hij zegt, ja, voor dat hele holistische.
Ja.
Ja, ja, ik wel. Goed, we moeten wel weten laat het nu ook een beetje op spullen lopen.
Los van dat het wel heel goed vindt hoe hij zijn hele leven hier aan
Vind ik ook. Vind ik ook. En wat hij allemaal nog steeds kan niet anders zeggen. Ik heb dat.
So I would be a cool.
Jawel, ik heb ertussen gewerkt, hè. Nee, ik heb een tijd, als ik die deed, ik werkte dus met Albert en samen. Dat is wel mooi hoor, want ik vond dat lang. Op een gegeven moment in de gezondheidswetenschap heb ik een stuk geschreven over harmonisatie, dit was meer
I just want to introduce myself. Thank you.
Innovatie.
Yes, yes.
Dus toen ben ik alleen maar met jou, zeg je,
Ja, I'm John Lee. Oh, sorry. Oh, beg your pardon.
Deze.
Call me when you want me.
Oh ja.
Oké. Dus ja, toen zei hij ook, ja. Dat een paar maanden dus kan mij denken.
Ja.
You're in Montpellier, really? How are you? Ask too many questions.
A lot of keloids you are doing?
I'm doing a lot of sleep. When are you talking?
Ja, en weet je wat?
Congratulations.
Ja. Zo zie ik dat inderdaad. Ik kom nu voor je doodgetekend.
Passion, remember, yes.
Soms soms.
There's not many of us.
Weinig.
Can I tell you something?
Oh ja.
Not out the country.
Ja, ik heb het daar gedaan.
Yeah, I gave it to you. Henry gave it to you.
Bij twee.
The memory sticks. Yes.
Ik ook waarschijnlijk echt timing, although I'm not British.
You're Norwegian.
Dan nog heb ik
Beautiful. There you go. Lovely, I remember now, yes.
Maar dat is gevaar.
No, but no, I agree. Yes, but it's difficult. And sometimes he says, oh, we have discussion now or after coffee. And I think much better, I like to talk to you after your presentation. I mean, no, I like that. Don't you agree with me? You don't obviously agree with me.
I agree, but
Met zit komen en als
Get it off, where? What is it?
like a VCC
is
or you have to get it checked by your
No, wait a sec.
dat ik het elke week doe.
I've had PCC, it's quite a lot.
Yeah, this one
Dat is eigenlijk het is ja. Sorry, ik mag niet over verschillen, maar het is af en toe dat ik
Dat is wel jammer. Of de ziekte tegenwoordig. Ik had even hierover. Over het moet om.
I think you're right. I need rid of it.
or maybe it's fiction. I would
Are you excited? Yeah, send it. I'm not certain. It could be that the shaver this morning, I got a new shaver. I mean, did you send it me?
Yes, I don't think that's the shape.
You don't think so? Okay, do you know my email?
wel het er meer uithalen.
Have you got a pen?
Do you have WhatsApp?
Yes.
Yeah.
My number, in order for WhatsApp to work, it has to be in your contacts. Yes.
Do you want to share my WhatsApp? Get my
Well,
What is it? Thank you.
Maar het is zo
You know, I don't have
Ja, maar hij doet nog wel incisief.
Ja,
Maar oren ook niet. Ik heb wel eens dat bij orenpatiënten heb gemaakt dat heen.
ja.
Dan
Ja.
Dus ik heb met hem over iets gezeten. Ja, niet op zaak. Ik heb het goed. Nog een keer bij heel goed zo die twee.
Ja.
Dus ja, je moet precies weten van wat patiënten elkaar neer. Ja, ik krijg onze patiënten bij mij eigenlijk. Ik krijg niet de hele pak over mee. Hij zegt, ja, maar weet je wat je eigenlijk bedoelt? Ik nuanceer het allemaal een klein beetje. Want je kan niet zeggen, de een of andere dag. Maar wat wel waar ik nooit groot is, kan je speel je ontsteken in je lijn. Kinderen met bepaalde voeding. En daar kan ik je een beetje van.
Een beetje afvallen op bank.
Ja, dan denk ik ook, nee. En dat zeg ik ook. Ik zou proberen te letten. Dat is één van twee. Ik zeg, ik geef een website mee. Ontstekingsdieet. Dat geldt ook voor je darmen en zo. Dus ik zeg, kijk, hier kan je zien, eventueel erger komt ook. Daar kan je kijken of ik nu voor producten, witpasta's en dat soort dingen. Zeg, en ja, ik ga het niet helemaal. Nee.
Nee, maar ik vind het wel jammer dat ze niet ingrepen is. Namelijk ook gewoon voorzichtigheid voor de afdeling. Want als je gewoon afdeling gaat, en dan met een lamp sluiten.
Kijk, het enige,
dan positie of iets dergelijks.
weet je wanneer ze komen? Wanneer er ineens dan zijn. Ik heb een paar keer gehad. Toen jij met over gewoon protuberans uitkomt. Ja, dan komt het erbij.
Ja, precies. Ja, dan zie je
niets.
Nee.
Eigenlijk anders, maar dat is best frustrerend hoor.
Ja.
Ja, of als het een kindje is met hele uitgebreide, waar die bij oren gaat.
Oh ja.
Bijvoorbeeld.
Ja.
Dat is niet vaak, maar dat is wel eens.
Ja.
Ja, en kijk, het enige wat wel eens gebeurt de laatste tijd vind ik want ik vind binnenkort kunnen we heel moeilijk krijgen in Nederland. Ja, de hele westerse wereld schijnbaar. Dus de merken die we hanteren, die kunnen we niet meer krijgen, dus ook andere merken. Ik vind het heilig. Dus ik heb ineens mensen bijvoorbeeld een probleem krijgen die ineens respiratoire een beetje insufficiënt worden. Meer spotting, ook al is het effect tijdelijk.
En hoe spuit jij ook gisteren? Weet je, was de discussie dus dat iemand A10, 1 of 5?
Dat is niet echt
homeopathisch.
Ja, echt. Ja, nee, ik ben heel heftig.
Oh, ja, 40.
Kijk, want wat is dat hij doet 80 max, hè? 80 milligram. Ik ook. Dus dat betekent 2cc40.
Ja.
Max 2cc A40. Soms ben ik met 10 ook wel heel truttig dat ik 2cc geef. Dan denk ik, ja, maar ja, weet je, liever rustig. Kijk, en zeg nooit tegen mij, hij wint het dus. Het zijn altijd zo onschuldig is.
Nee, ja. Nou ja, als je verkeerd inspuit, zijn er ook heel veel mensen, denk ik, inderdaad, die het gewoon onder inspuiten. Maar goed, ik heb daar ook niet eens echt, want kijk, wij krijgen dat 1 keer, 10 keer. Als je aandeels bent, wij van spreken, dan is het ook doe maar.
Klopt.
En dan is het inderdaad een beetje, ga je dan kanaaltjes maken, ga je dan het in 1 keer inspuiten en wachten tot het wit is. Je krijgt er niks in en dan spuit het er allemaal weer uit. Weet je, ook.
Want je naad komt ineens ergens weer eruit, terwijl je recht denkt te gaan, dan komt ineens, komt hij. Nou ja, Frank, als het goed is, ik heb 1 patiënt die bij het interview zit, die ook, want Frank wil een demonstratie geven op het gebied van injecties, die wil dat ook. Dus hij zei, welke dag, ik heb Frank niet meer gehoord, dus ik hoop dat hij dat morgen gaat doen. Ik heb geen kort fix. Maar ja.
Het is, hoe heet het, die PE-opleiding in Beverwijk,
Oh ja.
Die zei toen ook, pas net begonnen, maar toen sprak ik het idee. Ze zei al ook echt zoiets van, dan heb ik ook eindelijk een PA of zo. En hij zo, ja, physician assistant, niet je PA.
Niet je persoonlijke
Nee, want hij had ook echt dan kan jij dat even, dat in de agenda dan voor, dat regelen die poli dan. En zei ik echt, ja, maar dat kon ik niet doen.
Nee, is echt.
Dus ik ben hier niet om jullie polies te organiseren. En ja, echt.
Het zijn allemaal hetzelfde. Het zijn echt allemaal hetzelfde.
Ja, het kan echt een
hysterisch. En nee, maar dat vind ik zo jammer. Ik vind dit heel leuk. Ik had alleen met mama rekenen.
Ja.
Dat vind ik heel leuk.
Dat je daar eigenlijk dan
je ziet hoe weinig vier.
Ja, allemaal in andere landen zo.
Ik snap het ook wel, dat niet allemaal baby's kan zijn. structurele materialen
Ja.
gedaan heeft, behalve echt complexe types. En,
Ja, zeker. Dus ik daar nog niet zo goed mee kan.
Of bepaalde syndromen.
Ja, precies. Dat zijn hele ingewikkelde waar je inderdaad ook, ja, wij zien natuurlijk inderdaad veel via het APL.
Zeker.
Nee?
Nee. En mijn oudste is daar in baan nu. Die was al als hoofd. Ja, zou je
We're getting started. Please, everybody, have your seats.